Good afternoon, everyone. Welcome to Grand Rounds. Today, we are very excited to have Erin and Irene, our two speakers that are going to discuss the new ketogenic diet therapy updates and especially like what's going on at Dayton Children's Hospital, which is very great information to have. The session number for today is 2436. Again, that's 2436. On the slide that's showing right now, I just wanted to reiterate that both speakers have declared they have nothing to disclose as far as any financial, there's nothing financial that they need to disclose. So it's just important that we make sure that everyone sees that slide and it's right there. So again, the session number for Cloud CME 2436. If you have any problems getting in, let me know and I'll make sure that I can bypass them or whatever and get you into Cloud CME. So with that being said, I'm going to turn it over to the speakers and they're going to do a brief introduction of themselves and then we will get started. At the end is when we do questions and answers, Q&A. For those on Teams, if you have questions, again, please wait till the end. And Dr. Matson will, he monitors all of the questions that come through on chat. So he will make sure that to read your question and the speakers will provide an answer. All right, let's get started. And again, thanks everyone for joining us on this very cold day. And for those of you that have made the effort to come to the auditorium, we very much appreciate you being here. So thank you.
Hello, everyone. My name is Erin Talzzia. I am the old ketogenic dietitian at Dayton Children's. I worked on the ketogenic diets for about 6.5 years, and I have transferred that role over to Irene Conn, who is currently the new ketogenic dietitian, and she also works in the NICU. And I have transitioned to our community food equity role. And today we are here to talk about the medical ketogenic diet therapy, especially at Dayton Children's program and beyond. So we will be going over some landmark studies, talk about what the ketogenic diet is, describe our program here at Dayton Children's, what you might need to pay attention to if you're taking care of a ketogenic diet patient, and some recent studies and future applications. So we have this keto diet that people like to go on just regularly in society. So there's a lot of different thoughts and ideas about the ketogenic diet. So a lot of people who are on keto in mainstream society are likely on it for weight loss. And, you know, you see all these different things about pictures of before and after being on the keto diet, losing all the weight. So we have this like mainstream public perception that the keto diet is for weight loss, and that's the main reason for it. We also have some perceptions that it is a low carbohydrate diet, but I think that sometimes the high fat part kind of gets lost in the mainstream keto diet, and it tends to be a little bit higher in protein than in fat, especially because a lot of the recipes out there for the mainstream keto diet use really high fat meats and protein sources, and it tends to be a little less high in fat and a little bit more high in protein. So it's a little different than the traditional true medical ketogenic diet therapies. The other thing to note is that there are a lot of products out there on the market that are ketogenic diet products or keto friendly labeled, which there's no regulation on that label. So any product can put anything about keto on their label. And a lot of those products are low carb, but they are actually too high in protein and not high enough in fat for the medical ketogenic diet. There are definitely some products that really do work for the medical ketogenic diet, but it's not all of them. So it makes it really tricky for a lot of patients who are truly going on the medical ketogenic diet. And so we'll dive into what that really is from the medical standpoint here. So the medical ketogenic diet therapies are high fat, low carbohydrate, and then we say moderate protein, or another way that we might phrase that is adequate protein. So we want enough protein that the person on the diet has the right amount of protein to have skeletal muscle build up and to have all of the enzymes and proteins in their body that they need to function. But we don't want to overdo protein because we really want to focus on the high fat. So like the mainstream keto diet, you'll see a lot of your high fat meats used, but really we use a lot more like olive oil, mayonnaise, avocado, heavy whipping cream. So we're using really more primarily fat contents and not the just high fat protein kind of foods. The other thing to note with the medical ketogenic diet is that the carbohydrate content is net carbohydrates. So that means that we're subtracting fiber from the total carbohydrate in the food or meal item. And that's not necessarily always used in other contexts, but in the ketogenic diet community, we use the net carbohydrate. So when you think about carbohydrates, when we have fruits and vegetables that are really high in fiber, then we can subtract a fair amount of fiber from the total carbohydrate, and we can have a lot more of that fruit or vegetable than if we were just using the total carbohydrate in the calculation. So the medical ketogenic diet therapy induces ketosis because we lower the carbohydrate content in the diet so much so that there's not enough glucose circulating for the brain and the body to use glucose. And the body is always going to try to use glucose no matter what. So we have to lower it to an amount so that the body is forced to try and find another energy source. And we want that energy source to be fatty acids. So we, again, want there to be more fat in the diet than protein in order to have enough fatty acids to use for energy source. So the fatty acids are then processed in the liver, and the liver changes the fatty acids onto ketone bodies, and then the ketone bodies circulate throughout the body to the skeletal muscles and to the brain for use as an energy source. So then in the neurons in the brain and the skeletal muscle, the ketone bodies will then be made into ATP in the mitochondria. So instead of using glucose and to create ATP, we're using beta hydroxybutyrate mainly, but all of the ketone bodies. So we're forcing the body to use beta oxidation of fatty acids, which it doesn't normally use when we're on a regular diet. So why does this diet kind of work for neurological benefits or for epilepsy? We used to think that we just didn't know. And we saw that it worked, but we don't know why it worked. Now we just have a lot of different theories and a lot of different proven reasons why it could be working. And we know that it's just a multitude of mechanisms. So it's not just one reason why it works. It's all of these reasons kind of combined together is why the diet might work. And therefore, we don't have the ability to mimic that with one drug because we know that it is a multitude of mechanisms of action. So what are some of those mechanisms of action? So we primarily know that the ketone bodies used by the neurons are less excitable. They change how the neurons fire in the brain, and this helps to produce less seizure activity. We know that the ketone bodies alter the activity of the mitochondria in the neurons, and it also alters different chemical pathways, specifically the ATP-sensitive potassium channels, which all of that helps upregulate GABA in the brain, which helps reduce seizure activity. We also have studies now that show that maybe it's actually also glucose stabilization that can affect the seizures versus the high fat component. And we even have a drug that is being researched for the glucose stabilization effect of kind of what the ketogenic diet has done. And then we also have found that the alteration to the gut microbiome from the diet plays a huge role. So we know that anytime we change our diet and especially our macronutrients, our gut microbiome is going to respond and change as well. So we see from several studies that this does happen with the ketogenic diet. So there are studies that show that kids who are on a ketogenic diet will have higher levels of certain bacteria in their fecal matter and lower levels of other bacterial in their fecal matter than those who are not on a ketogenic diet. And we also have seen in mice studies that those mice who are on a ketogenic diet, if we give them antibiotics that completely deplete their microbiome, they will then have seizures when they had seizure control while on the ketogenic diet. And if you take a mouse that was on the ketogenic diet and transplanted their gut microbiome into a mice that wasn't, they will also have seizure control. So we know that there's a huge correlation between the gut microbiome and seizure control when it comes to the ketogenic diet. But then we have some studies that maybe don't always show that that's the only reason. So from all of these different components, there's multiple mechanisms of action of why the ketogenic diet works, which is why we can't pinpoint it and create a drug to mimic what the diet itself would do.
So when we're talking about the ketogenic diet in the medical context, there's actually 4 different types of diets. The first and most commonly used type is the classic ketogenic diet. And this diet is calculated in a ratio of grams of fat to grams of protein and carbohydrate combined. So for example, most commonly you would see a 4-to-1 ratio. That means there's 4 grams of fat, and for every 4 grams of fat, there's 1 gram of protein and carbohydrate combined. On the classic ketogenic diet, 90% of calories are coming from fat. So that is when you think of what you're typically eating in the day, that is very significant if 90% of your calories were from fat. In addition to the 4-to-1 ratio, the classic ketogenic diet can also be made into a 3-to-1 ratio, which allows for a little bit more carbohydrate and protein in the diet. And this is more appropriate for example, infants who might start on the ketogenic diet. Historically, calorie and fluid restrictions used to be employed with the ketogenic diet, but there's not really evidence of benefit from that or even any evidence to support doing that in any way. So most centers don't restrict calories or fluid. And then in practice, typically we would apply the classic ketogenic diet for children who are less than 2 years old, or if they are exclusively enterally fed, then they would be a candidate for a 4-to-1 or a 3-to-1 ratio. The next type of ketogenic diet is the MCT oil diet. So in this version, it's basically the same as the classic ketogenic diet, except that of the fat proportion, most of the fat in the diet is coming from MCT. So instead of depending on long chain triglycerides, we're looking at getting most of our fat from medium chain triglycerides. And the reason for this is that MCT oil can yield more ketones per kilocalorie of energy than long chain triglycerides. So you need less total fat in the diet. And so therefore, you can include a little bit more carbohydrate and protein. You have more food choices with this version. A big drawback of this version of the keto diet is that a lot of children cannot tolerate the amount of MCT oil required for this diet. So it can cause a lot of gastrointestinal discomfort. So we don't use it very frequently or regularly at all here, but you might see this a lot more at like an adult ketogenic diet center. And the third type of ketogenic diet is the modified Atkins diet. So the primary difference between like the traditional Atkins diet that you would think of and this is that we are primarily focused on just limiting our carbohydrates. So we ask families who are following this diet to limit their carbohydrates to 10 grams a day, typically in the first month. And then in the second month, if things are going well, we can liberalize it a little bit more. So sometimes going up to 20 grams of carbohydrate, and that's per day. So families do not have to use specific recipes provided by the dietitian. They can, their child can go and grab a cheese stick for a snack versus if they were on the classic ketogenic diet, they couldn't just go grab a snack. They would have to follow a specific recipe that we gave them. If they wanted a cheese stick, they'd have to pair it with extra fat on top. So modified Atkins is a lot easier, and we use it with children who are older than 2 or adolescents. Yeah. Then we have the low glycemic index diet. And this diet doesn't necessarily produce any ketones, but it's based on that hypothesis that maybe just looking at stabilization of glucose levels could help with seizure control. So on this diet, most fruits and vegetables, beans, minimally processed grains, pasta, low-fat dairy, and nuts can all be included. And those things would not be easy to include or could be included at all on like a classic ketogenic diet. So in practice, we might use this diet on patients who have Angelman syndrome. There's been some case reports that have shown for that syndrome specifically, particular benefit from this diet. Otherwise, we would use this diet for families who are finding that even the modified Atkins diet is too restrictive and too much of a burden for them to follow. We could start here and see if there's any benefits found, and if things are going well, then maybe we would restrict further.
So the ketogenic diet was originally kind of thought of in 1920s. Russell Wilder came up with the ketogenic diet prescription, and that was based on the fact that there had been like case reports and some other kind of literature that maybe starvation or fasting can actually cause seizures to go away. But you obviously can't starve a patient forever. So there needed to be some way of mimicking that. And so he came up with the ketogenic diet that would induce kind of a similar environment to starvation or fasting. So he had this prescription that he published in the Mayo Clinic in 1921. And then we had Dr. Peterman, who actually took that prescription and he implemented it with a group of patients. So he published the first study in 1925, where he had about like 17 patients who had some success with seizure control while doing this prescribed ketogenic diet. So then there were several researchers that also researched patients with the ketogenic diet, and they were having some success with seizure control. So in the 1930s, Dr. Fritz Talbot published a book about the treatment of epilepsy, and he actually included information about the ketogenic diet because it was that showing that significant of a promising treatment for seizure control. So that was the first ketogenic diet book published in 1930. So you can see that about in the 1920s and 1930s, we had a lot of studies from a couple different researchers that were showing about 45 to 86% of patients trying the diet would have a 50% or higher decrease in seizures while on the diet. And we were, really showing promising effects from the ketogenic diet. But then the pharmacological boom for the anti-epileptic drugs kind of stagnated that progress in the ketogenic diet. And so even most of the research was being done out of Mayo Clinic. Mayo Clinic stopped really investigating the ketogenic diet and publishing studies on it because we had these new drugs that were doing similar things to what the ketogenic diet was. And it was thought of as a lot easier to take a pill instead of, alter all of these aspects of life while being on the ketogenic diet. So it was particularly like Dilantin that came out in the 1937 that kind of halted the whole progress of the ketogenic diet literature. And then in the 1990s, we started to have an uptick of studies on the ketogenic diet. And that was really fueled by some of the kind of media around this certain patient named Charlie. So this one boy named Charlie, he was struggling with epilepsy, and his parents were trying all these different drugs on him, and they were going to all these different centers and nothing was working. So he was not responding to the drugs that were available. And they eventually came across the ketogenic diet and worked with Johns Hopkins. And then Charlie was seizure-free on the second day of the ketogenic diet. And he has really been seizure-free since then. So the family felt very strongly that like this was an injustice done to him because they had tried all these things and no one had ever talked about the possibility of this ketogenic diet. And they had to find that out on their own. So what they did was they created the Charlie Foundation to kind of help other families and medical centers know that the ketogenic diet is an option that's great for patients who are not responsive to drugs for seizure control. And that also led to an ABC aired video or movie called Do No Harm. And so the media kind of hyped up the ketogenic diet a little bit more, leading to centers going back into doing research. Yes.
higher prevalence of failing to respond to therapy, having good response to the ketogenic diet?
There are some that respond a little bit better to the ketogenic diet and some that maybe don't respond as well to the ketogenic diet. There's not anything to say that like there's certain epilepsy syndromes that don't respond to meds as well, but like when there are patients who do have those syndromes that don't respond to meds, then the ketogenic diet is a good option for them. So like one of them is infantile spasms. So there's a couple different medications that are specifically targeted for infantile spasms, but the ketogenic diet seems to have really high success rate in that population specifically. So that one is used a lot more in the infantile spasms group. Doucet syndrome, absence seizures are two other group types that if they're intractable to medications, then they'll use the ketogenic diet and have a lot of success with the ketogenic diet. But I'll kind of review some of those a little bit later in the presentation as well. Yeah. We are having a little technical difficulty that the slide's not advancing. So, okay. Oh, yeah. Okay. Perfect. Okay, so like I said, in the 1990s, we started to see more research being done on the ketogenic diet again because of Charlie and his family and the work and media attention that got. So there was a bunch of different studies started again, and we have this like landmark study that basically we show that about 50% of children who try the ketogenic diet will have some type of positive response. So again, this is not like, it doesn't cure epilepsy for every child who goes on it. It can, but it really, we see that there's patients who will have like some type of seizure control from the diet. So we also had some studies that were published around that time frame that showed that the likelihood of a person responding to a third anti-seizure medication when they didn't respond to the first two was pretty low. And so that showed that like there was a need for something other than seizure medications to get some kind of control over and treatment of epilepsy, which then supported using the ketogenic diet in practice because we could see that there was all of this evidence to show that it was unlikely that someone would respond to more and more anti-seizure medications if they failed other ones. So this also led to 26 international neurologists and ketogenic dietitians to come up with our first consensus statement on how to manage the ketogenic diet. So in 2008, there was a convening of this group, and they produced this paper that basically informed people how to implement the ketogenic diet, what things to monitor, who to try the diet with, how to maybe stop the diet. So this was huge because during that pharmacological boom, we stopped training neurologists and dietitians on the ketogenic diet. So there was this kind of education gap. And this consensus statement really helped other dietitians, other neurologists, new centers to be able to implement the ketogenic diet without having to like do all of the work on their own. They could follow like this blueprint of how to do it at their center. And then we also had our first major 2 randomized control studies that actually proved the efficacy of the ketogenic diet in 2008. And so that really created this high demand and attention for the ketogenic diet because we actually had really, the most controlled research to show that it could be better than placebo or medications. So since then, there's definitely been more research, and they are searching more and more about the mechanisms of action for the ketogenic diet. And we also have our new updated guidelines in 2018 about how to implement the ketogenic diet. So some of those differences are kind of the nitty gritty about like what types of epilepsy syndromes respond a little bit better. The fact that we don't need to focus so much on the beta hydroxybutyrate as we thought we had to previously. Maybe a little bit more about the side effects and how to manage side effects and prevent side effects that the ketogenic diet does have. So these are kind of our big open landmark studies that promote the ketogenic diet.
Okay, so how does the ketogenic diet program work here at Dayton Children's? So any child who is identified as a possible candidate to trial the ketogenic diet can be referred to our ketogenic diet program. Typically, they're considered a candidate if they've tried 2 anti-seizure medications without success. We do allow some families to consider the ketogenic diet independent of what medications they've tried or how many, but they're referred in a different way. So it is recommended that patients try at least 2, and if they fail those, then they should try the ketogenic diet. Typically, patients would be referred to intractable epilepsy clinic, and there in that clinic, then the neurologist would meet with them, dietitian would meet with them and go over what the diet is. Again, because a lot of people, when they think of the ketogenic diet, they think of, some of the fad diet things that we talked about in the beginning. So we talk about the diet, everything that's involved. I believe a social worker also meets with them at that time. And then after that clinic visit, families decide if they want to go forward with following this diet.
So we have a pretty good list of some of the types of epilepsy syndromes that respond really well to the ketogenic diet. The research at least leads to that. The one I highlighted earlier was infantile spasms. So the drugs to treat infantile spasms do have a fair amount of high side effects that are common and serious side effects. And so the ketogenic diet is a really nice option. There are some centers that even might try the ketogenic diet for infantile spasms before the drug interventions. But here we do usually try 1 or 2 of the other drugs before pursuing the ketogenic diet for infantile spasms. And the other 2 I really wanted to highlight was the GLUT1 transporter deficiency syndrome and pyruvate dehydrogenase complex deficiency. So those are 2 metabolic disorders, so inborn errors of metabolism disorders that have to be on the ketogenic diet. So those, they need a different energy source than glucose, and so we give them that by giving them ketone bodies by putting them on the ketogenic diet. So there are then some other contraindications to the ketogenic diet. So anyone who has a primary carnitine deficiency, like another inborn error of metabolism, could not be put on the ketogenic diet. And the reason, because we need carnitine in order to metabolize and move fatty acids around the body. So if we don't have enough carnitine to do that, then we can't utilize the fat that we're taking in for the source of our energy. We also have a couple different beta oxidation deficits or like deficiency syndromes that cannot be on the ketogenic diet because we can't do the beta oxidation, which we would need to do in order to have success on the ketogenic diet as well. So those are some some kind of really rare conditions where we would not be able to pursue the diet, and it would be important to not try it on those patients.
With the ketogenic diet, this diet is not nutritionally complete, and there are some significant side effects and risks that we go over with families. So these things are really important for families to know about when they're trying to decide if they want to pursue this option for their child. So common side effects are hypoglycemia, acidosis, constipation. Every child on, no matter what type of ketogenic diet they're on, will have constipation, and weight changes. Some patients will gain weight, some patients will lose weight, and we just have to monitor that closely and adjust as needed. Risks, growth stunting can be common, so a lot of times patients won't meet or reach their full height potential if they're on this diet. Kidney stones, hyperlipidemia, decreased bone mineral density because of the dietary restrictions and because the bones being in an acidic environment, that's not healthy for them. They don't like that. And then just general vitamin and mineral deficiencies or hypercalcemia can occur. So once we've gone through how the diet would work, all the risks, the side effects, if families decide that they want to start their child on a ketogenic diet, then we ask them to commit to a 3-month trial period. We want to make sure that we give the diet a fair shot. It's very burdensome and difficult for families to do this. It can be really hard for the patient as well. So we ask them to give it 3 months. A lot of times, if the diet is going to work, it will show its benefits in 4 to 6 weeks. But there can be late bloomers, so to speak, or if they're having difficulty in the beginning, getting started or getting into ketosis in the very beginning, then giving that full 3-month trial period is really helpful. So we ask them to commit to 3 months, and then before they start the diet, we get a large panel of labs. So we need to know, where are we with certain vitamin and minerals? Do we have any deficiencies before we even start the diet? We get a fasting lipid profile. We look at acylcarnitine and amino acid profiles to rule out any of the contraindications that Erin mentioned. We also look at a urinalysis, CMP, and CBC. Depending on the type of diet that the family chooses and is recommended for their child, they'll either be admitted or they can do everything outpatient. So if a child is going to start a classic ketogenic diet, then they are admitted to the hospital for 4 to 5 days for close monitoring, and we advance the diet daily based on how they're doing to get to their goal ratio. If they're doing a modified Atkins diet or like the low glycemic index, then we can do all of that outpatient, and they just have a couple hours to spend with the dietitian to get all of their education, and then they can go out and start that on their own. About a week after starting the diet, I try to give the patients a call. We have close communication, lots of follow-up. Depending on which type of diet the family is on or the patient is on, the dietitian and them are going to be in closer contact. Clinic visits, we usually want to see the patient back in clinic a month after they've started the diet, and they'll meet with the dietitian and the neurologist. And then after that point, every 3 months.
So as we'll see them every 3 months, we want to make sure that certain things are okay with their blood levels, especially because not everything can be symptom-based when we want to intervene on something. So we will get a CMP, magnesium, and phosphorus. So we want to make sure the electrolytes are all normal because sometimes we do need to supplement electrolytes. We also are looking at the CMP because we want to make sure that they're not experiencing acidosis. So we look at that CO2 level to make sure we don't need to intervene in that standpoint as well. We, of course, want to make sure that they don't have crazy high triglycerides or cholesterol, so we get a lipid panel and want to make sure that's staying kind of in an okay range. We are looking at their beta hydroxybutyrate level because we want to see kind of, how much they're in ketosis, or at least that it is elevated enough to be like considered on the ketogenic diet. And we will try and get a urinalysis just to make sure that they're staying hydrated enough and making sure that they're not having some kind of predisposition to kidney stones, which can also be a risk. And then a lot of times the neurologist will get anti-seizure drug levels. And that is because the ketogenic diet causes the body to metabolize everything differently, including medications. So there are studies that show that some of the anti-seizure drugs will actually decrease in circulation because of how it's metabolized differently on keto, or there'll be some that will be increased in level while on the ketogenic diet. So they want to make sure that the levels are good, or if they need to try and either increase the drug or decrease the drug based on the levels. And then annually, we also want to look at our vitamin mineral levels, especially those that we're most concerned about while on the diet. And we look at the carnitine panel to ensure that we don't need to add a little bit more carnitine because the body is just using so much carnitine to metabolize or to mobilize the fatty acids that we maybe need to give it a little bit more. And then amylase and lipase in case they're having maybe some pancreatic insufficiency or pancreatitis symptoms. So typically, while they're on the diet and at home, they will be monitoring 2 different things. So they need to monitor their blood sugar at home, and they need to monitor ketones. So blood sugar, we will teach the family how to use a glucometer, get them all the supplies, and they need to do that at least once a day, typically in the morning when they're like the longest time fasting. And then we also teach them the symptoms of hypoglycemia to see if, to make sure that they can identify when they need to be checking their blood sugar additionally and how to treat that. So the other thing they would monitor is ketones. So at home, they use urine ketone strips, and they do that once daily. We will typically want them to do it around the same time every day, but it doesn't matter when they do it during the day. Ketones are typically higher in the afternoon, evening time. So sometimes families prefer that time frame. And then there are blood ketone meters that can be used to check the beta hydroxybutyrate level in the blood. However, the insurance insurance does not cover those, so we don't prescribe them. And some families will choose to purchase one, and those do have studies to show reliability with them, and so we'll use that information instead of the urine strips, but we don't require that of our families because it's already expensive enough. So in addition to changing how they're eating, they're also adding 2 different kind of needed monitoring things into their day. So it's not just changing what they eat, they have to do some extra stuff at home as well. And then we also will change their medication formats. So as you know, there's a lot of medications that don't taste very good. So we add a lot of sugar to those medications for kids to take them. But then our kids on the ketogenic diet really shouldn't be having those high sugar forms of the medications. So even some of the anti-seizure drugs can provide like 15 to 45 grams of carbohydrates for a patient, which you can imagine then would not make them successful to be in ketosis or on the ketogenic diet. So a lot of those forms are going to be changed to tablets, but not all kids can, swallow tablets, especially if they're younger or have dysphagia. So we crush a lot of the tablets and they'll mix them either into something to eat or drink or give them through the G-tube. Occasionally we can do some compounded sugar-free suspensions, or if insurance will approve it, injection for oral forms from specialized pharmacies. And then the personal care products are something we also sometimes will change for patients. Now, there are some dermatologists that will tell you that the carbohydrates in your deodorant and your soap and your shampoo, conditioner, lotion, bug spray, sunscreen, all of those things are too big of molecules to be absorbed into the skin and then into the bloodstream. And then other dermatologists will tell you, no, they're definitely can be absorbed and enter the bloodstream. So there are some different practices on whether or not we have children change their personal care products. A lot of the lower carbohydrate or carbohydrate-free products are hard to come by. They're a little bit more expensive. So here we don't require them to. We just adjust the diet prescription. We change some other things before we might change the personal care products. However, if a family is using certain products, we've adjusted the diet, they're in a good spot, and then all of a sudden they change a product and now they have less ketosis or they have a seizure, then we might have them change that product specifically to a different one because we've proven there in that instance that that's not a good option for them. So there are definitely some kids who are more sensitive to personal care products and the maybe carbohydrate that can come from them, and then other patients could be on anything and it really wouldn't cause a difference in their ketosis. So as we continue on the diet, if it's working for them, we definitely want to monitor all of their different levels, but then that means that we a lot of times are adding supplements into the diet. So for any patient on the diet, typically the diet is not going to provide all of the micronutrients, vitamins, and minerals they need. So we prescribe, or we tell the families they have to do a multivitamin, which that can be a little difficult because, again, multivitamins for kids typically have a lot of sugar in them. So we have to find the right multivitamin for each family that they can afford and that is a good option for the ketogenic diet. And then depending on what that formulation provides, we might add calcium and vitamin D on top of it, or depending on what their pre-ketogenic diet labs show. So those are things that are like kind of baseline across the board. But then we have some other supplements that we might add on while we are on the diet and kind of optimizing it. So MCT oil is a huge one that we'll add. So like Irene talked about, there's a specific diet called the MCT oil diet, but a lot of times we'll use MCT oil as a supplement on top of the classic or the modified Atkins diet. And that's because it will boost ketosis, it gives them some more fat, some more calories possibly. It will also allow them to have a little bit of a laxative effect since the ketogenic diet constipates, then we'll get the laxative effects from the MCT oil. There are studies that show that MCT oil in isolation of the ketogenic diet may have seizure benefits. So it's like why not try it, right? Because it can be a really helpful thing to add. And then carnitine, of course, we want to monitor their carnitine panel, we might add that as a supplement. We will do fish oil, especially if we're struggling with cholesterol issues. And then any patient who will have acidosis, like mild acidosis on the diet or severe acidosis on the diet, will start an acid buffer. And so that looks like Efferk or sodium bicarbonate here. There are a couple other options that other centers use, but these are the ones that we typically use. So Efferk is actually a potassium supplement, but we like that potassium citrate component and citric acid component of that medication that really does treat the acidosis effect. And once they're on an acid buffer while they're on keto, they have to stay on it. So it just continuously helps make them in like a better neutral environment while they're in ketosis. Now we'll use sodium bicarbonate or baking soda if we need to. Sometimes parents don't want to add a supplement like F4K on it because it's another medication. You have to get it from the pharmacy. But baking soda will help with acidosis. It just doesn't help with preventing kidney stones like the citric acid potassium citrate does. We will also add table salts or Morton light salt, so the KCl component, if we need anything for electrolyte adjustments, and then Fosnac for phosphorus.
All right. So when do we stop the diet? Well, if we've completed the 3-month trial and no benefits were perceived, then we can stop the diet. Or if the diet is found beneficial for those first 3 months, then we would continue for 2 years. And at 2 years is when a discussion is had about the risks versus benefits of continuing. Long-term use of the ketogenic diet can increase risk of kidney stones, bone fracture, and again, it's just a very significant burden on families. So sometimes at 2 years, patients will come off of the diet and a lot of times still continue to experience the same amount of seizure control. How do we stop the diet? Patients will gradually wean down on their diet ratio. Depending on how well their body responded to the ketogenic diet, that will dictate how quickly or how slowly we might wean down on the ratio or other components of their care and what's going on with them medically.
So you might see ketogenic diet patients in the hospital or in a different clinic, and there are just some things that it's important to think about when you're taking care of these patients. So the biggest one when you're admitting them to the hospital is no dextrose. So when we're reducing carbohydrates to such a low limit, if they are put on dextrose-containing IV fluids, usually it takes an hour or two to reach their total max carbohydrates for the day. So we obviously don't want to give them crazy amounts of carbohydrates through the dextrose and the IV fluids. So you're going to use either lactated ringers or normal saline or half normal saline, maybe some additives in there if you need to. Now, the important thing is that if you leave a patient on the ketogenic diet on normal saline or half normal saline, it's important to check electrolytes maybe a day or two after if they're not advanced to their actual diet. And that's because the sodium chloride tends to make them acidotic if they've been on that just for a while. So we want to make sure we're cognizant of the fact that like they could become even more acidotic if we're just like leaving them on the IV fluids. Lactated ringers tends to be less acidotic promoting, but it's still important that if we're like keeping them on IV fluids that are non-dextrose containing, that we check their electrolytes at some point. So when you take care of a patient, the goal is always to maintain ketosis for seizure control. So that's just, we want to make sure that we're trying to be cognizant of that. But also we want to treat the patient just like we would treat any other patient. So a lot of times we have a lot of people reach out to us. They're like, oh, what should we do? This patient's on keto. What should we do? But there's a lot of things that you can do that you would do just for any other patient. But keto sometimes tends to like scare people like, oh no, they're on keto. Like I can't do this. So some examples of this is like if you would have feeding intolerance, a patient on ketogenic diet, you would treat them just like a patient who's not on the ketogenic diet with feeding intolerance. So you would slow their feeds down, change the bolus size, give them bowel rest, maybe change the formula. So it's just important to keep in mind that like, yes, we need to be cognizant about like the fact that they're on the ketogenic diet and we need to try and maintain ketosis, but also we can treat them just like a lot like other patients and make interventions just like a lot like other patients would. And it's just something to like think about. We can, you know, what we want them to be like in ketosis, but we can also treat them like we would treat other patients. Now, if we have a life-threatening condition or an emergency and whatever the treatment is would cause them to come out of ketosis, we do recommend that you do that, and then we'll resume the ketogenic diet after they've been stabilized. So some examples of this would be like if we had a huge hypoglycemic emergency, yes, give them a dextrose bolus. If they need steroids because they're intubated in the ICU, steroids are going to cause them to be out of ketosis, but it's important for them to get extubated to be on steroids. Another example is if we are restricting protein a little bit with the ketogenic diet, sometimes we need more protein for like wound healing. So maybe we would reduce the ketogenic diet or take them off of it if that's inhibiting their wound healing with the protein restriction. So the other thing we want to be cognizant of is their glucose level. So their range that we want to aim for is 50 to 80. So that is obviously low for other people not on the ketogenic diet. So we want them to be like pretty much more like in the 60s, and we don't want to intervene if they're above 50. Now, if they are below 50, then we do want to give them a treatment for the hypoglycemia. It's not like a crazy like emergency, because there are other centers that have cutoffs that are 40. But here we want to be a little bit more conservative and have our cutoff be 50. So we will give them 2.5 grams of carbs, so either 15 mils of juice or a dextrose containing bolus, and then recheck the blood sugar in 15 minutes and repeat it as needed. So we don't want to give them the normal treatment for hypoglycemia, because that would be way too many carbohydrates. Now, if they're having multiple lows and we can't seem to get their blood sugar to stabilize, then we will recommend an IV dextrose infusion, but it was not going to be at the same rate as like you normally would run IV fluids. So it would be something that the dietitian would work with you to not give them too many carbohydrates, but give them enough to make sure their blood sugar is not always going to be low.
Okay, so orders to place when you're admitting a patient on the ketogenic diet. There's kind of some standard things that we just want to make sure are in place for all of these patients. And you can also find these in the Dayton Children's ketogenic diet guidelines, which is on Focus, I think in the Medication Resource Center. So we want to put, we need an order for seizure precautions. Acute illness can cause an increased risk for more seizures. We would like a consult to the dietitian. That just helps alert the ketogenic dietitian that the patient is here and they can start working on anything that they need to work on. Some lab work. So while the patient is admitted to the hospital, they're sick, so we would like close monitoring of their blood sugar and of their ketones. So daily blood glucoses, or even every 4 hours if they are fasting or NPO, and then daily urine ketones are helpful. And like Erin mentioned, checking electrolytes regularly is also a good idea. We want to make sure that all medications are in the lowest carbohydrate form. So if anything new is started, you need to keep this in mind. Also, when putting in home medications, making sure that the form stays the same. Fluids, Erin kind of touched on this already. Outside of IV fluids, we don't want to use Pedialyte because of the carbohydrate content, but you can use Gatorade Zero or Propel if they eat by mouth or are using a feeding tube. As far as their diet order goes, you can place, if they eat by mouth, you can just place a ketogenic diet order, and then in the comments, add any texture modifications that that patient might need. If they eat by mouth, then the dietitian and the kitchen work together and we plan every single thing that that patient eats the entire time they're admitted. So so it's just very important to have that dietitian consult in, or if the consult's not in yet, but like patients in the ER and they're going to be admitted soon, like being in touch with the dietitian is a really good idea. Our kitchen is not open 24 hours. So if they eat by mouth, there's a lot to coordinate. There is a keto TPN option. There is a specific order set for this. And keto TPN does not look like regular TPN. It's basically just a lipid infusion and fluids. So the pharmacist and dietitian and physician can work together on creating this for the specific patient needs. And then what we see most of the time here is our tube-fed buddies, and you can talk with family to collect the recipe that you need for their formula order, or you can always look at the last dietitian note and it's usually there. Here at Dayton Children's, we regularly stock just 2 types of ketogenic formulas. One has an intact protein and the other one is peptide-based. Both of these formulas are a 4-to-1 ratio. But by adding other ingredients, we can manipulate that ratio. So getting that recipe from the family is really important for us to know what we need to do. If an admission is planned and the patient is regularly on a different formula, we might be able to get that in advance. Or if the family is, if the patient's on something different at home, the dietitian will work with them to figure out the best situation for when they're admitted. Any patients that come who are on the ketogenic diet and they're managed by a different diet center, we will typically not change anything in their regimen. If we do need to change something, then we get in touch with their neurologist, their dietitian, and work really closely with them to do that. So sometimes families have questions about making changes, and we just defer to their ketogenic diet program. Again, just to highlight, the ratio of a 4-to-1 ketogenic formula can be changed by adding other ingredients. So sometimes a family might tell you, oh, my child's on a 3-to-1 formula, and they might say, you know, Keto V or Keto Cal or something like that. But and you would call down to the lab and we don't carry that here. Well, then you just need to ask some more questions. What else is added to the formula that the family is using? So there's just a little example there of like Keto V peptide 4-to-1. By adding these other ingredients, we can bump it down to a 2-to-1 ratio.
So most of the research that is being done now recently is more so what other applications of the ketogenic diet are there out there. So we mostly see a lot of research being done in the cancer population, especially in brain tumors. So the first study with the ketogenic diet and brain tumors was in 2014, and that did show tolerability and that ketosis could be achieved in the brain tumor population. But of course, we're not going to do like randomized controlled trials with the ketogenic diet and normal protocols for oncology, because that's just like too high of a risk. So a lot of the studies in the brain tumor population is more so self-electing that they'd like to try the ketogenic diet on top of their protocols. So it's a little bit of a tricky kind of research area because of those kind of considerations. We also have some other brain disorder research. So Alzheimer's disease, there's a pilot study at Johns Hopkins that's showing that a high-fat, low-carbohydrate diet can slow cognitive decline on early Alzheimer's disease patients. So that's another area that's being highly researched. And then we have a lot of robust research on type 2 diabetes in the ketogenic diet. There was a 2022 analysis that showed that the ketogenic diet could reduce body weight, hemoglobin A1C, and triglycerides. There is a lot of research that shows you can take patients off of their diabetes treatment medications if they're on a ketogenic diet. And then we just want to highlight, though, that there's not enough research for a lot of these areas. So we're still needing to figure out like the dose of the ketogenic diet for brain tumors and other cancer. We still don't know if Alzheimer's disease is really a good treatment option to put on them on the ketogenic diet. But even though we do see that their ketone bodies can help decrease memory decline. Diabetes is, in 2019, the American Diabetes Association did support ketogenic diet treatment for type 2 diabetes, but I think that's, something that also, families and patients need to determine if that's something that they would like to pursue for the diabetes treatment. And then we have some research that shows that, like for obesity and weight loss, the ketogenic diet could be an option. Obviously, with new drug developments, that's maybe something that's kind of on the back burner as well. And then a lot of patients with autism, families will want to try the ketogenic diet. We don't really have any good research to say that it's has good efficacy. And it also might be difficult to implement the ketogenic diet with a patient who is selective eater, and a lot of kids who have autism are selective eaters. And then we do have some research to show that maybe for migraine attacks and cluster headaches, the ketogenic diet can be helpful, but we also need more research there too. And that was it. Thank you so much for listening. And if you have any questions, let us know.
Okay, so I have a question. You talked about how it's a big lifestyle change, and it's often very hard to figure out what good options there are because there's no regulation on the labels of keto. So, first question is, when you get a family that's adopting it for their child, does the family tend to adopt the diet as well, so it's all together and more successful? Uh, and what tips do you have to give to the families to help them know what's good keto versus just a label?
So we will allow, I guess is a word, or maybe encourage parents to maybe try the diet with their child, or at least to, when they're eating meals with their child, to maybe do the diet with them. But we do strongly discourage any other children in the household to do the diet along with their siblings, because we're not monitoring their like electrolytes or any of their like possible side effects. And I mean, and as an adult, a lot of times there is some time away from a child, so they could ingest carbohydrates outside of being with the child. But there are definitely some parents that are like, oh, I want to do it with them because I think it'll be better for their child, and we definitely support them in that endeavor. So definitely some families do, other ones don't necessarily adopt it. And then for the difficulty of figuring out the products, we will teach them how to determine if a product can be used on keto or not. And that's by reading the nutrition facts label and figuring out if there's enough fat in it and not too much protein, to kind of help with being able to incorporate it. And if they can incorporate it, does that mean that they have to eat something else with it, or is it in itself okay to eat on its own? Now, there are like a lot of labeling where they'll subtract all of the alcohol sugars from the carbohydrates, and that's not the practice that we do on the ketogenic diet. We will subtract like 50% of erythritol and then 20% of the other sugar alcohols. So we tell them if there's any sugar alcohols, then they should definitely be wary of the product, because that definitely is not as net carb low as it's promoting it to be. So we'll again teach them how to like kind of do those calculations and how to read the label to be smart about what to choose.
Hi, thank you for the great presentation. Super helpful for me as a resident. Two-part question. First part is, how many of the patients that you treat are oral fed? Because most of the ones that I've seen inpatient are G-tube dependent. And for the ones who are fed orally still, have you noticed any different ethnic groups that have a diet that is more conducive or more friendly for achieving and maintaining ketosis, knowing how closely tied different cultures and ethnicities are to different foods?
Yeah, that's a good. Great questions. So offhand, so we pretty much have between 20 to 30 patients on the ketogenic diet, Dayton Children's, at any time. And that's like a rolling number. So, there's patients that'll come off the diet, but then there's patients that come on the diet. So it's always around between 20 to 30. I would say that probably 25% are oral eaters. So we have a like large majority are tube fed. But we do have a fair amount that are oral feeders. But it kind of changes, based on who's starting the diet and who's coming off the diet. But it's like definitely a hard diet to try. So we will have a lot of patients who maybe oral patients who will try it and be ones that will come off of it sooner than 2 years than our G-tube fed patients. Some of the oral eaters that are a little bit more successful are usually those who have developmental delays. And so they maybe don't really know exactly what they're eating, or like they're just happy to eat kind of thing. So it's a little bit easier in that population sometimes. But I would say that for the different cultural or ethnic like cuisines, from my experience, a lot of my patients have been, traditional American cuisines, but I've had a handful of patients who are Indian, and their cuisine is a little bit trickier because it's a higher carbohydrate based cuisine, especially if they're vegetarian. So there's definitely like a lot of kind of tweaks and things that we have to do with like that population. I haven't had any kind of diet preferences that already lead to being like a good option for keto, if that makes sense. But also we're a small center compared to like some of the other centers are huge and have like an insane amount of keto patients and have like 4 or 5 dietitians on staff because they're so big. And so I'd be curious to see what like they've experienced. Yeah.
If you do have infantile seizures and a kid that's orally feeding, can you still incorporate any direct breastfeeding into this plan? And how do you like monitor and do that?
Do you want to take that? Or do you want to-
Well, yes, but I have not had experience with it, so I'm going to let Erin give more details.
Yes, so there actually have been some studies that they've done where they will allow the infant to direct breastfeed and then they follow it up with a high keto formula or maybe some MCT oil. So we can definitely allow direct breastfeeding. It's typically timed, so we can't like just let them do their whole feed because we do need to follow it up with something, but we definitely can incorporate direct breastfeeding on that diet. And there's been like great success with like those studies that have showed that. And then another way that we incorporate breast milk is when we do it through like a formula that they drink, or sorry, that they, if they're not direct breastfeeding and they drink from a bottle or have a tube, we will incorporate the breast milk as the carbohydrate component when we calculate their formula. Or if they're on a 4-to-1 ratio, then we will just add some more oil or MCT oil to kind of offset the breast milk that's in that recipe. So it can definitely be used. Yeah.
One last question.
Yeah, very quick question. Would you mind going back to your slide on the supplements?
Oh, yeah.
There was just one I didn't recognize on there that I wanted clarification on.
Yeah.
Yes, what was the what did MCT stand for in the MCT oil?
Yes, that's a great question. MCT, I'm sorry, I didn't say that earlier, is medium chain triglycerides. So medium chain triglycerides are metabolized in the liver and they bypass other direct or other metabolism routes. So they are different than the long chain triglycerides that do traditional metabolism. And they tend to produce more ketones than long chain triglycerides. So MCT is not like an essential fatty acid. So we have to have other oils or fats in the diet to make sure we're getting those. But they're typically oils. There are some powders out there, a little harder on keto because some of them have carbohydrates added as a powder, but mostly like an oil that they would like drink or add to like whatever food that they're eating. Yes, you're welcome.
All right, that's all the time we have for today's Grounds Rounds. Thanks for participating. Friendly reminder, your session code is 2436. Once again, that session code is 2436.
No, I think it's fine. I think it's the slide. I'm pretty sure it's like. Oh, well, thank you. I think it's. Yeah.